Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to a very special podcast. This is a podcast celebrating the 20th anniversary of the NEI Congress. And of course, there's no one better to talk about this with than the founder of NEI, Dr. Stephen Stahl. Steve, how are you?
Hey, Andy, great.
All right. Well, we have some very interesting questions here, just in general, and then we actually have questions submitted by our podcast listeners. So first, I heard you took really good notes in medical school and that your peers would ask to borrow them. Is this true?
Well, yes, I was actually ahead of my times. If you go to give a modern lecture to a medical student today, if you have, you'll find that there's two people in the front row with some sort of an MP3 player. And they record it, and then they either make their own notes, and they play it back much faster than you actually delivered it, and that's what happened. Well, that was me, actually, I have to say it. I graduated from medical school 50 years ago this coming May.
Oh,
and
my
yes,
goodness.
I was always on time. I was one of the guys in the first row. I never missed a lecture, and sorry about that. But and in the future, they didn't even have to go to the lecture. They just got the notes from the current people.
That's right. They don't even go to class now. They get it all virtually.
Right.
But Steve, you told me once that you had to kind of go over things a few times and that you developed this technique of drawing diagrams to help you understand. And eventually, I believe you got someone, an artist or graphic artist, to help you with this. Can you tell me about how that evolved?
I'm a visual learner, and if I can't see it, I don't understand it. And I'm not a very good artist, but I could kind of sketch things out. And so if I could, even without really having very good pictures in a tangible sense, if I could visualize it in my head, then I could understand it. And I thought I was an oddball, but it turns out that at least 40% of people are visual learners, not essentially auditory or oral learners. And so that's how I ended up giving my lectures. I would actually create that, and then somebody looked at my lectures and said, you ought to put that in a book and write it up as a textbook. Then eventually I did that.
Well, that was sort of the foundation of NEI, wasn't it?
Yeah.
Steve, I remember before you founded NEI, we were doing educational programs such as the academies and things like this. And you originally started doing these talks that were multimedia. I remember I went to one of those back in the day. So you had this idea, I believe, to get funding support from pharma companies and develop these rich multimedia type presentations. Can you tell me a little more about the evolution of NEI?
Well, the evolution of NEI was also based upon a secret, which I'm going to disclose now if you're ready for it.
Okay.
The secret's called Nancy Muntner. And so Nancy was able to take my ideas and convert them, essentially translate them into art. And one of the secrets of being able to make things readily accessible to a professional audience is to basically make Nancy understand it. Now, if you take a highly intelligent woman like this, who's not actually trained as a psychiatrist, but very smart, and if once she gets it, she can, with some of my crude hand-pecked things, put it on paper. And it kind of is the principle that a lot of people like to lecture and say, at the end of the day, I don't care if you understand this, but I want you to think how smart I am. I talk really smart, fast, and wow, they're going to say, I don't know what that guy said, but boy, is he brilliant. And then mission accomplished. No.
Yeah.
What you need to do is to say, look, this is not that difficult. And in fact, what I've found is that when things are difficult, they are not understood by anybody. And so it's really the ability to simplify them that shows you when you actually know it. And then people like Nancy converted into art. And then, of course, over the years, Nancy then made the art move. That's called an animation. You can put it into a PowerPoint. And then, of course, the artists and the content people at NEI have all kind of come along with that heritage, and they've just been able to clone that and expand it.
Yeah. So Nancy is the artist who brought your ideas and your drawings to life. When did you first meet Nancy? How long have you known her?
I met Nancy as an undergraduate. She was an undergraduate at UCSD, and I was a professor when she was still an undergraduate.
Wow.
So that would have been in the 80s, I think like 1989. So we actually wrote the first book in, I think, 95, but we were doing a number of, visual presentations, like you say, the academies and things like that, and slide sets in that interim. She actually was a research project manager for multi-center trials that I was doing of new drugs. And she did this on the side. And I bought this funny little thing called an Macintosh.
Oh.
It was a type of Apple. And so we went from the Apple II to a Macintosh back in the 7,000 generations ago. And she's stayed in the Mac environment in the last 30 years. So that was how it started.
Okay. Well, NEI was obviously founded with the desire to help patients by helping the professionals who treat them to do a better job using the tools we have. And as you've said, medical education is a visually rich field. You have really created the visual language of psychopharmacology that simplifies complex scientific concepts through this innovative use of visual elements, both the diagrams, the static pictures, and the animations. How can these illustrations or animations help promote the understanding and retention of this material?
Well, it makes the abstract concrete, maybe hyper-concrete. And some criticisms would be that's not a simplification, but an oversimplification. But, it's like, I think you have to understand rules before you can understand exceptions. And so rules are obviously incomplete and, have exceptions. And so really the concrete, in fact, Nancy and I have this secret weapon, which I'll reveal to you now. It's a special scope. We can look into the brain. And did you know that serotonin was yellow and that dopamine was blue with triangles? And so I'm teasing, but of course
I do now.
we created that, and it turns out what's very funny about that is if people don't understand the jargon, but they understand the visual representations, then they don't need to understand the jargon. And the other weird thing that happened by inventing the visual language of psychopharm like that is it looks the same in Japanese, and it looks the same in Spanish. And so what ended up happening is that people who didn't understand English at all, or not even as a first language, got these concepts just as fast as anybody that did in English. And that was an accident. We didn't even realize that would happen.
Right. Do you have a sense of how many languages the textbook has been translated into?
Well, I've heard it's 11. And so I think it's 11 to 14, something like that.
Yeah, amazing. Well, Steve, I remember our very first NEI Congress in 2004 in San Diego. It was in the Gas Lamp District. We had a little place there near the convention center. There was a brand new Hilton Hotel, I believe. How has the NEI Congress evolved over these past 20 years since we had a couple hundred people at that first one, I think?
Well, it's evolved from a couple hundred to several thousand.
Exactly.
And it's, a major, if not the major CME conference in the world right now. And it evolved from essentially me doing essentially all the lectures, at least in the days of the academies, which were the things that occurred before that. And then I did 80% of them. And then I realized as seductive as it is to be the center of the universe and to be the star and the celebrity of all this stuff, it really wasn't a long-lasting legacy you can leave that way. And so the way to build it was to bring in other people. And I had to bring in these people that were very special, like yourself, and you're actually perhaps one of the greatest examples of that. in which people realized that it wasn't about them. And of course, that's kind of hard to find in academics. There are three basically components to a learning environment. It's the presenter, it's the content, and it's the participant. And in almost all learning environments, especially in medicine, where there's a lot of smart people learning it and there's a lot of arrogance to how important it is, content is king. And the more content you can cram in, the better. Even though, if you have 1,000 pieces of content, you remember very few of them. But if you have 10 pieces of content, you remember all of it. And so there's actually diminishing returns, but nobody respects that. It's like, here's the content. If you're not smart enough to get it, to hell with you. And, you're not smart enough, you don't deserve to know it. And that kind of arrogance permeates most medical education. But the second in command, if content's king, then the presenter is either the crown prince or the crown princess, right? Because it's about me. I'm a very busy person. I'm very important. I hardly really want to lecture because I really would rather do research or do something that would make money. So, yours just should be thankful that I'm here at all. And so, I'm going to do the things that make it convenient for me and how presenting is good for me and convenient for me. And if you don't get it, too bad. So, we had to find people to say, no. You're a servant. The content is a servant. And the king is the participant, and it's all participant focused. And we know that by doing it that way, the participant becomes empowered, because often you're demoralized by the traditional, I'm stupid, I can't get it, and there must be something wrong with me. Obviously, I'm supposed to get it, and I didn't. Oh, wow, am I dumb? And then they leave demoralized. Whereas on the other hand, if you actually have people understand it, they get empowered, they get excited. And the other thing is that they won't apply the learning unless they're not only learned it, but they are another thing, confident. Yes. So people like you, Andy, and your colleagues, and the number of people that we recruited to NEI over the last 20 years have all been that special kind of person that was able to put their ego aside and to actually subjugate the content and themselves to the participant. And then what's interesting about that is it becomes even more about you when you do it that way. Because the participants say, who did this for me? Oh my God, that Andy Cutler, he's an amazing guy. I listened to his lecture and I learned something and I can apply it and I'm a better clinician. Thank you, Andy. They don't say that when they don't understand you. Yeah. And so the lecturers came to understand how important their role was in the participants then being able to change what they were doing to optimize it, and then to actually hundreds of people in their practice were affected by that. So you're lecturing 100 people in the audience, even the multiplier effect is 100 times 100. Right. And so, my gosh, the ability to affect people. So people like you and our audience, our faculty, came to believe that the most important thing was moving the field towards better practice, not making yourself glorified or making an honorarium.
Right. Well said. Well, Steve, I don't know if you realize it, but you just revealed another one of the secrets of NEI besides Nancy Muntner, illustrations, animations, and that is NEI was founded on principles of adult education. And I'll never forget, Steve, back in the beginning days, you would bring some of us newbies in, Les Citrome and Jonathan Meyer and some others, and we would have these boot camps for a weekend where we were trained by Rick Davis and inculcated in principles of adult education. And I'll never forget this concept of participant focus, learner focus, how it blew my mind. So yes, I think that's something unique, too, about us.
The thing is that once you get to a certain stage in academia or in the field as a key opinion leader, KOL, whatever the heck that is, then you don't have to worry about anything anymore, right? Because you've made it. Wrong. I always told people at these boot camps, you ever hear of a person, for example, by the name of Michael Jordan?
Yes.
I got two questions for you. Number one, did he practice? And number two, did he have a coach? Well, if Michael Jordan needs to practice and have a coach, who is it to say that you and I don't need to do the same? So part of the practice was to know what's coming up in your slides before the slide is there. so that you can anticipate it and use teaching techniques that were able to develop this in a stepwise fashion.
Mm-hmm.
And the other thing was to get coached. And so we did that at those sessions. I still get coached. There's issues about fill speech. There's issues about stupid things that you do, mannerisms that are off-putting to the audience, and they need to be constantly refined out. And your coach will tell you sort of like on your 3-point, you're beginning to fade to the left, and that's why you're missing, etc. So this is what we did, and it really made a big difference.
Absolutely. And then the other thing, of course, was I'll never forget you sitting me down and saying, look, Andy, I don't just want the most famous academics. I want great teachers and great communicators. So I think back in the day, a lot of us that you had picked, we weren't necessarily as well known back then we are now. And I think that was another secret too, was we've carefully picked our faculty. We train and develop them. We assist them. We give them the tools they need. So I think that's part of what makes NEI special. The other thing, of course, was your idea was to have a single track. And a lot of other meetings will have several talks at the same time, which I think is confusing and frustrating if you want to see two at the same time. So that leads me to another question. How have we maintained the quality as NEI has grown? That's always a challenge when something grows.
Yes, it is. And it's by being fussy about, how you leverage that, because one person like me can't do it. And so you grow the faculty, and we continue to grow the faculty.
Yes,
and the other thing is to find people that are actually dedicated to the philosophy. And I will say that, there's a famous quote by Maya Angelou, and I'll say it here. And this is, if you go to an NEI meeting, or you talk to somebody who's reading one of our books at the end of it, they will feel good.
Mm-hmm.
And usually because they're empowered and they can figure out, they can go out and say, oh, I get ground down by all the crap in my professional life, the prior authorizations and the billing and the collections and the no-shows and the whatever, and then the frustrations that the medicines don't always work. And but then you go to a meeting or you read something that is inspiring, and you actually say, this is why I became a mental health professional. I feel good about the choice I made. And also, I feel empowered to go back and hit it again. And after reading something, there's a book, and then, of course, the Congress came out of a book, and now, And so let me give you what she said. She said, they will forget what you said.
Mm-hmm.
They will forget what you did, but they will never forget how you made them feel.
Uh-huh.
And so the issue is that what keeps this growing is, and what's very incentivizing for the people who are the leaders and who have taken over and are the faculty, is that idea that and the staff at NEI, the writers and the project managers and the artists, is that that your work makes people feel good, and they leave with a pep in their step and willing to go back and hit the grindstone again. And I've never seen that in any other meeting. We actually didn't do it on purpose. It kind of was an outgrowth just of our philosophy, and so that's really cool. And I think that's what, is part of our legacy, and what makes the speakers come back, and what makes the participants come back, and what makes people stay at NEI.
Absolutely. And I can tell you, amongst the faculty, there's an incredible camaraderie and esprit de corps. We really enjoy each other. We actually hang out with each other in between talks, and that's also a little bit unique. You also made me think of something, making people feel good. Integral to the meetings, of course, is our NEI Focuser videos. And maybe you can help me understand where those came from and what the theory of those is.
Well, the idea is that you're thinking of 100 things, like how hot your coffee was, or the fact that there wasn't the right protein there at the bar, and you're coming on in and wondering about where your parking ticket is. And so you have to focus. And one of the ways to do that is with humor and with music. And we have some of the most crazy people. We've got Megan writing the most amazing lyrics, and Debbie, singing and doing songs and putting it all together. and having just 2 minutes, usually, or something in that range, of where you take something and make fun of it, or you use it as a starting point, change the words. And this will actually irk some people that in a funny and a kind of delightful way. We have, for example, I can think of one song, Have You Ever Been Inflamed? So if you actually hear that for 2 minutes, it's about inflammation in and it's in your head all day. You say, I can't get this thing out of my head, which is nice because it makes you remember about the role of inflammation and things. So it works. So you just take 2 minutes, they stop what they're doing, they stop thinking about their parking ticket, they're thinking about what's coming up, and then they're ready to go so that they're focused. That's called a focuser.
Got it. Yeah, and one of the principles of adult education that I learned through NEI also is that adults actually learn better with a little bit of humor, and they retain better. So they learn and retain with a little bit of humor. So that is also wrapped up in what we do, I believe. There's a
they say it's a significant emotional event associated with the learning, makes the learning sort of like embedded maybe deeper into your amygdala or wherever it goes. Yeah. And so that significant emotional event can be, some of our focusers are sad. The ones about PTSD almost make you cry. Yes. But it's usually humor. And the humor associated with if people laugh about that, they think of the peens, the don'ts, 2 pips and a rip. People still think about that. But then they learn about all the different types.
We're going to come back to that one. We're going to come back to that one, Steve. I have a question from the audience about that one in a minute. There's so many, the dorsolateral, prefrontal, PFC, there's so many of them that stick in people's heads. I want to get back to the textbook and the evolution here. So expanding on the concepts central to the Essential Psychopharmacology textbook. NEI's taken this visual language of psychopharmacology that you and Nancy created. We've taken it off the page and into live events at the Congress. The Congress makes the textbook come alive. And also online through our website and NEI membership activities like your videos, Stahl's Essential Videos. How does the integration of visual language in these various learning formats help to create effective learning programs?
Well, most of us are visual animals, and it's actually easier to see a live meeting or an animation than it is to actually look at a static picture in a book and to use words around it. And so there's also the principles of repetition. So, for example, in the live meetings, you can say things 3 ways, which means by the time you get to the third one, you're probably remembering it. So you're going to say what you're going to say, often with words. Then you say it with slides. And then sometimes you say what you said with an animation, which then summarizes a 30 or 60-minute presentation in 2 or 3 minutes of movements. And all those are different ways until they finally embed in your, again, your amygdala, wherever it goes, and you remember it. And so if you associate it also with feeling good about it and feeling empowered because you understand it, then it's actually powerful to do it in a live meeting. It's more powerful than doing it in a book.
Well, you just reminded me of something else you told me, Steve, about yourself and how this evolved. You had told me, and this was hard for me to believe, Steve, that you had to sometimes go over something again and again until you got it. I always thought the magical Stahl saw it once and that was it. But this idea of repetition is very important.
Yes, and a part of the humility that you get by taking a complex concept that is new and trying to simplify it is how hard it is to do that. And so we all can do that, but I have the time to do it because that's what I do for a living. People who are going to the lecture, they could do it if they take this several hours and go over it and read the literature and do all that stuff, but they're busy. So why not give it to them in 30 minutes instead of 17 hours? And so there's a project we're working on right now, which has to do with the role of glutamate in cognitive improvement and impairment associated with schizophrenia. That concept has taken us hours, and we're putting together with Megan and Nancy and myself. We've spent dozens of hours on it, and we'll end up with 3 animations, each 2 minutes long. And so that makes it look easy. Well, the idea is to make it look easy, but then to make it look not easy to say, oh, isn't NEI or Stahl smart? That's not the idea. The issue is it's easy and I'm smart. because I'm a participant and I get it. Thank you. And you've saved me all that time. So yeah, we have to go through things. There every new one, the new one with the new drug, cholinergic drug, and trying to understand the mechanisms of that and making it simple, has taken many, many hours. But that's our job, and so we do it with delight. And it takes time, and there are many false runs, and the animations are not clear, and the pictures don't look right. Many times. So all the failures, you don't get to see the sausage making behind the scenes.
That's right. But I think it's good to model for our audience the humility of this, that you and I have to go over things a few times till we get it. And sometimes the first time they might hear it at an NEI meeting, what we tell them is, look, we're just introducing you, we're teasing you, and hopefully you will get it after a few more times.
Yeah, actually, let's talk about that for a second.
Yeah.
It's sometimes the 3 stages of learning where, and in some ways, it's good enough to just move one stage. So when you come in and you didn't even know something, that's called ignorant bliss. And then you hear it from Andy, and Andy did an eloquent job. You say, oh my God, now I know I don't know it. And so, they say, well, is that learning? Yeah, because it creates a situation, a to-do list. You say, all right, I'm not supposed to know it the first time I see it, but I didn't even know I didn't know it. Now I know I don't know it. I'm going to get to it.
Exactly.
Well, if you know you don't know it and you're already at that stage, then Andy will take you to the stage that it's hard really to get it, but you almost know it, and you're close to knowing it, but you're not skilled at it. And then the people who kind of know it, but go through it again, they become very skilled at it, become second nature. So we want to move people one stage along, and that's why no matter where you are, you can't expect yourself to move more than one notch.
Well, that brings me to another unique feature of NEI meetings, and that is the pre- and post-test questions and the audience response system. And so part of that is to take somebody from being the unconscious incompetent who doesn't know something, and we give you these questions that you may not know, and you go, oh my gosh, I don't know this. And now you're in a receptive learning state, and hopefully by the end, after the lecture, you get the questions right, and now you're a conscious competent.
Let's tell the listeners a secret that you and I know, which is that those keypads are not just something that grades the audience.
Right.
It also grades the teacher.
Exactly.
And so what happens when you and I get back the fact that we didn't teach to that point, and people maybe in some cases didn't learn much. And in fact, you and I have both we're doing this extensively over time. You'll even have experiences where you unlearn someone, where they seem to know the right answer more before your lecture. You say, oh my gosh.
That's right.
And so it tells you how to improve as a teacher, because you get that feedback. It says, I was not effective, or I was very effective. And so the keypads are good for teachers as well as the participants.
They are. Steve, a little bit of trivia for our audience. They may not realize that the first person to use audience response keypads in any medical meeting anywhere in the world was you.
Well, that's kind of funny because I stole it. There's an old saying, I wish I could say I invented the keypads and I'm brilliant and every so forth. No. What they say is clever invents, genius steals. So where did I steal it from? I stole it from Rick Davis, who was teaching salespeople for the auto industry how to tell the difference between this year's Toyota compared to, a Ford. And so they use keypads for this. And I thought, oh my gosh, why don't we do this in medical education? Because it takes a lot of effort. It's hard to write the questions. It's difficult for the developer. And, let's make it easy for the developer. It's not about the participant. Well, those people who were spending their money training these people on the auto salesmen had to have these salesmen come in on Friday and know how to sell a Toyota by Monday, and actually had to do something with that knowledge. And so they applied it, and I stole it.
Well, you're certainly very honest about that, and I've told that story to many people, and they're always pretty amazed. It's so ubiquitous now, these audience response keypads that we use. Well, Steve, another thing that you told me in the very beginning, another part of your philosophy for NEI was, look, we don't have a blood test or an X-ray to match the right medication to the right patient. So if we can teach our learners how to understand the mechanism of action and often receptors and things like that, perhaps we can at least match it to the right clinical profile or understand what the risks and side effects are. And that brings me to my next question, which is, we now have a new generation of mental health care providers who've been trained with this visual language you've created of psychopharmacology. Where do you see this future now of psychiatry going, and how do they stay ahead of the learning curve?
I think the future is going to be more neurobiological empowerment. So, these diagnoses, I just was reading something before I came on this podcast, thinking about the lecture I'm going to give at NEI. And one person said, well, maybe terms like major depression and schizophrenia will be discarded like dropsy was. And it's a term because these illnesses are so variable and different that, teaching how to treat schizophrenia is kind of a fool's errand because there's 6,000 or 60,000 types of schizophrenia.
Right.
And when you've treated, 6 people with schizophrenia, you've treated, 6 people with schizophrenia.
Right.
And so the real clinician knows that each person in some ways has his own disorder. If they have the Stahl disorder or the Cutler disorder, and individualizing the specific treatment profiles to the specific patient while being neurobiologically empowered is the best we have. We have no markers at this point. So hopefully we'll have them in the future. But in the meantime, what we have is endophenotypes. So if a phenotype is a description, we don't have any biological phenotypes, which means, this cholesterol level means you need to give this drug. We don't have that yet. But what you have are things like anhedonia. What you have is things like problems with attention, grief. These are symptoms. And so we treat symptom profiles, not disorders. So being neurobiologically empowered to understand the circuits and the neurotransmitters that regulate each specific symptom allow clinicians to have a fighting chance to use drugs that modify those neurotransmitters in those circuits to try to, if you really are doing, is increasing the efficiency of information processing so the circuit stops having the symptom.
That, what you've just said succinctly, Steve, is one of the most exciting things for me when I first joined you, was exactly that. And the idea of going viral, as you said, I'm a little grandiose. If I can help 100 providers or 1,000 providers, that's 10,000 patients. So we're going viral, helping a lot of people that way. I think the future of psychiatry is very bright. There's, as you know, a lot of innovation, a lot of money is flowing in, and the fact is you need the money to do the research and to develop the innovation. So this is an exciting time. Steve, I'm going to shift gears. We have now some questions submitted from our listeners. We have questions submitted on social media from our NEI podcast listeners and our members. First, what has been the most rewarding moment in your career?
Well, I've thought about this, and I think the answer is when I realized that my books and the NEI live things were having an impact. And so it's very cool to think that you matter. And so all of us want to do that. And everybody who's seeing patients and the suffering they relieve proves that they matter. And what happens is that if you can help them do that better, which is the kind of thing that you and I do for a living, it makes me feel like I have mattered. And so, as you may know, if I've gotten some more recent honors that look back at a long-term over a career. And it's because, we've now published almost 90 books over 25 years with, like I say, 11 or so languages, with over 2 million people read them. And so, and in NEI, we now have thousands of people coming every year. And you multiply that, the multiplier effect of how we've been able to affect with these tools, the books and the Congress, the practice of medicine in psychiatry throughout the world has been the most rewarding moment in my career.
That's amazing, because you did recently have a very significant honor at Cambridge. And Steve, you met the Pope. I would think one of the most rewarding moments is meeting the Pope, working with him and the Vatican on mental health. You even sent me a picture of you with the Pope it was hard for me to believe. But that must have been rewarding too.
Yes, and so, having policies so that we can bring these medications to our patients is also part of what you realize is one of the deficiencies of a practice. So what good is creating new drugs for schizophrenia, for example, if, as I read recently, only about 25% of people with schizophrenia right now are under treatment.
Wow.
If our policies don't get these medicines to people and we don't have ways to treat people who don't even know they're sick because of the ethical controversies, which is why we went to the Pope. I mean, how do you make somebody well if they won't take their medicines, but if they've got a disease in which they don't even know that they're sick or that their medicines work? So it's an ethical dilemma, and we have to sort that out in order to bring the treatments that we have to these people.
Right, absolutely. And Steve, you've also worked with the state of California and the judicial system to do a lot of work on improving the system around the care of people with severe mental illnesses.
Well, there's a thing called Care Court, which is a model for the future, creating controversy, of course. Why? Because the criteria, therefore, for involuntary treatment is no longer violence or, harm.
Right.
So that you have to be harmed or harm somebody in order to get treatment or commit a crime and lose your civil liberties. The criteria now is evolving to be much more Italian. In fact, my boss right now at the state hospitals is over in Italy right now talking to other people, because the criteria for treating people who don't want to be treated is if they can't make healthcare decisions. If you can't make a healthcare decision in dementia and you're walking around naked, wandering, people are not going to say, well, he doesn't want to be treated. Let's just let him do that. They say, no, George, come on back. We're going to sit you down, get you warmed up and stop doing that. You can't wander. But with schizophrenia, we allow them to do it.
That's right. Yeah.
In fact, I saw when I was reading this thing today, getting ready for this lecture, as I told you, so a new thing, they called it sidewalk psychotic. So you see people psychotic on the sidewalks now. They don't belong there.
Right.
And so the idea is to say, no, you can get treatment if a judge will listen to the sides of the arguments for and against that. And if it's determined that you can't make healthcare decisions for yourself, we'll restore your dignity and your basically capacity to understand by giving you treatment.
Amazing. So you have not only revolutionized medical education, you've been working on systems of care to allow people to get these new treatments that we've been developing. Steve, I have a little more of a whimsical question. Do you have a personal favorite illustration or icon from your textbook?
Yes. It's the free radical. I don't know if you've seen that, but free radicals are these sort of species that destroy parts of the cell. Well, Nancy made a picture of a free radical, which is a 60s level hippie with a sign that says "The end is near," and so that's the representation of the free radical.
Fantastic, I love it. Okay, we have a question now about management of patients. For patients with acute bipolar who are well managed with lithium, would you continue with the lithium instead of an anticonvulsant or antipsychotic? What's the gold standard for maintenance of bipolar?
Well, the gold standard undoubtedly for maintenance for bipolar mania is lithium. It doesn't work as well, and some people can, but it is not as robust on the maintenance of the depressed phase of bipolar. And so Jonathan Myers and I, bless his heart, Jonathan has written so many recent handbooks that are really great service to the field. And really, I just helped a little bit. But Jonathan did the lithium one. And in that, it really is, and it's becoming more of the standard for mania. Why? Because Depakote is falling out of favor because it is causing problems with modification of your genes that can create problems with, children, even to change the sperma in men. And so basically Valproate is being more and more pulled from the market throughout the world for people of childbearing age. So yes, lithium is probably the key for mania.
Yeah. Steve, I remember when we first started learning that antipsychotics could work for bipolar disorder. And the first APA guidelines back in the early 2000s that mentioned atypical antipsychotics for bipolar were very clear. They were for acute use only. I remember, not for maintenance. Well, that certainly changed. We now have several that are approved for maintenance. So I think those are reasonable too. And then, of course, lamotrigine, as you mentioned, probably better from stabilizing from below or helping prevent bipolar depression. So lots of options. The bottom line is the best thing is the thing that works and is tolerated, that the patient will take, I guess, right?
Right.
But lithium, I'm glad to say, does appear to be having a renaissance, largely sparked by you and Jonathan. All right, Steve, a personal question from our listeners. If you had to choose, what other profession besides psychiatry would you practice?
Well, the short answer may be music. I had to give up my trumpet.
That's right.
Because I didn't have enough time. But I played in Dixieland bands and Tijuana brass type bands, in pit orchestras. I actually even had for a short time, a SAG membership, a union card to play.
Really?
We did summer stock and playing, for MAME and Hello Dolly and these things 17,000 times in a row. And I really enjoyed that. So maybe music.
Yeah, that makes sense. People may not realize what a talented musician you are. I remember one year for the Congress, do you remember you came out dressed in a Mexican poncho and a big hat with your trumpet, and people didn't realize it was you and you were playing the trumpet, and the big reveal was it was Dr. Stahl. All right. One of the most significant barriers for newer trainees is to learn the neuroscience and psychopharmacology of psychiatry, how complex it is, especially mechanisms of action of the drugs and the neurobiology of the brain. How do you simplify complex concepts, Steve?
Well, first of all, you have to kind of read all the data, and so you can draw a box around it. You say, well, the solution's in this box. So you have a lot of disparate kinds of pieces of information, and then you try to synthesize it. And what ends up happening is that when you find a solution, it's probably correct because nature actually is simple. And if it's a simple solution, it's probably the right one. If it's a very complicated one, it's very likely to be wrong or only partially right. But, the answer really is to find learning sources that do it for you. Now, of course, if you're interested in medical education or you're interested in research and hypothesis testing, then, one of the things you would take complex things and try to make a hypothesis out of it, knowing that in a Popperian sense, the philosopher of science, Karl Popper, basically hypotheses are basically supposed to be wrong. You're supposed to falsify them. And so the idea is to create a hypothesis and then prove it's wrong. And so if you have a hypothesis that's named like the Cutler hypothesis, Cutler's not going to be too happy if it's wrong. True. And so that's part of the problem, is that people will not falsify their own hypothesis because it's too much identified with them. And so that's wrong. And so what you should do is you create simple hypotheses if you can. And if you don't have the time, go to great educational sources. Hopefully we're one of those in which we do it for you.
That's right. Well, Steve, I've always said one of your true gifts is an ability to translate these complicated concepts into straightforward, understandable ways for people to digest them. And that really is quite a skill, and there's a lot of art to it as well. All right, Steve, we're going back to the focusers. So can you please update the peens, the dones, 2 pips, and a rip? We now have a roan in lumateperone and a lean with xanomeline.
Oh, my gosh. All I can say is that please go home and start chewing on a betel nut.
And why would I want to do that?
Though a betel nut has been prehistoric. It's like thousands of years old. Yes. And it kind of soups you up and kind of gives you some pep in your step, energizes you and makes you think better. And then the betel nut is a substance called arecaline. And arecaline has been modified to a new drug called xanomeline. And what is it? Arecaline is a muscarinic agonist. It was one of the first ones. So somehow or another, we're going to have to put a song together that has to do with chewing nuts. Now, don't chew the mushrooms. Don't chew mushrooms. That has the psychedelics in it.
Well,
and don't choose coca leaves because that's got something else in it. But if you have a betel nut, you can chew that one.
Yeah. You know, my good friend, our good friend Rakesh Jan told me that all over India, people still chew betel nut, and it's given to them to help them with focus, to calm down, and for digestion of all things. We know about the muscarinic effects in the gut. All right, so we're going to work on that. We have to update our songs. Okay, this is a great one for you, having worked a lot in the state hospital environment in California. How can I pharmacologically manage a patient with resistant schizophrenia who cannot use clozapine for one reason or another?
The short answer is by turning your headlights on. Do you drive at dark ever? And hopefully when you do that, you turn your headlights on? Well, in treating resistant schizophrenia, your headlights are something that most of us weren't trained to do. But I learned at the state hospitals, and we wrote a book with Jonathan Meyer on it, and that's called Plasma Antipsychotic Drug Levels. So if somebody isn't responding, although many drug levels don't work for many reasons and across the field of psychopharm, and they're not that useful in people for first-line use of people who respond to the usual doses of the usual drugs. But if the patient's not responding, get a level of the drug they're taking while they're not responding.
Yes.
And if the level is low, it tells you one thing. And if the level's normal, it tells you something else. And so if it's low, obviously, there's something that's going on, and you raise the dose, or you figure out, what the problem is. And then raising the level will make the drug all of a sudden work. But the more common one is that the level is normal, and they still don't work. And so there's a couple of ways to do that without using clozapine. And although many people have used two drugs together that are both antipsychotics, I do not recommend that. The plasma drug level book says that in such patients, there is a level above the usual that you can aspire to until a thing we call the point of futility. And if you want to look it up, we can even send you the PDF of it. There's a table for the most commonly used drugs. And you need to push the level to that point. And you will find many people will respond that haven't responded before. Now, the one weird thing that can happen now is unknown, but I'm betting on it. I'm betting on a thing called bad math. I love it. I'm a psychopharmacologist, and Andy knows this joke of mine. We say we can't count. Because if you actually increase the levels, it's a little bit like good math, where 1 + 1 = 2, and 2 + 2 = 4, more and more and more is linear. But if you combine, let's say, a dopamine 2 receptor blocker with something else that works for psychosis, like a muscarinic agonist, there's the possibility of bad math. What's that mean? Where the outcome is greater than the sum of the parts. 1 + 1 = 10.
Yes.
And I don't know that that'll happen. It's still in progress, and it may only happen to some people.
That's right.
But another possibility for treating resistant psychosis could be, don't know this yet, there's still trials in progress, but when that drug is actually available, that's what I'm going to do with it, add it to D2 antagonists to see if I can get a better outcome.
Yep, certainly makes sense. Steve, I remember you and I filmed a video several years ago called Searching for the Outlier, and I think people can look that one up. It's on YouTube. But another thing I think it's important to tell the audience is I don't think you can call somebody treatment resistant until they've had a good trial of an LAI. Because for the very reason you're saying, people don't always take their medicine, the blood levels aren't consistent.
You know what? I get very mad at these new drug companies. They keep making drugs that don't work unless you take them. I keep telling you, why don't you make a drug that works if you don't take them? Well, until that happens, how about an LAI?
Yeah. I mean, LAIs are still probably pretty underused in our country. All right, moving on, we have a question about what might be a good approach to treating comorbid adult ADHD with OCD.
Well, if ADHD is more of a dopamine-related phenomenon in terms of inefficient circuits that are controlled by dopamine and that get made more efficient by raising dopamine, and OCD is a condition in which the circuits are regulated more by serotonin, Then the issue is you combine a so-called dopaminergic drug, mostly a stimulant, with a so-called serotonergic drug.
Yep.
And so that's the place to start, at least.
Yep.
Sometimes, there are very, very severe cases, in which case the combination of these things, people are very nearly psychotic.
Yes.
In other words, particularly in OCD that's very bad, they get to the point where they actually lose the insight that their obsession might be excessive, and they start to believe the obsession. And that's the border between an obsession and a delusion. And if that occurs, then you probably should be thinking about one of the atypical antipsychotics.
Yeah, I agree. There's actually literature on augmentation with atypicals for resistant OCD. And I would say, Stephen, I don't know if you agree with me, that of the stimulants, I would probably use an amphetamine over a methylphenidate, because amphetamines actually do increase release of serotonin to some degree. There's a serotonin syndrome warnings in the amphetamines, but not with methylphenidates. So that just sort of makes sense to me.
Yeah.
Okay. Next, this one, we could spend an hour on this topic, Steve, so we don't have a lot of time left. But what does the future hold for Alzheimer's disease?
Well, I'm hoping a lot. We're kind of been working on it for a long time. It's a personal one as well as a professional one. Both of my parents died with Alzheimer's disease, so I'm sitting here shaking in my boots. Yeah. You'll have to be the judge at the end of this podcast whether it's set in already. But, I think that we may be barking up the wrong tree with the amyloid hypothesis in terms of it being the be-all and end-all. It turns out that amyloid does accumulate, and it's the question is it the cause of dementia? So does amyloid cause dementia, or as seeming to be happening now, does dementia cause amyloid?
Right.
And so if you suck amyloid out of the brain with the current drugs, amyloid comes out of the brain, and, it might cause a little bit of bleeding and some of the, but it does come out. The question is, does it really halt or slow or even reverse the dementia?
Right.
And it doesn't necessarily look robust.
No, I agree.
And so we might be targeting the wrong thing.
Right.
And it could be that the pivot to, from, the beta amyloid to other things could be the way to go. So I'm hoping that it does. We have good markers of dementia, but I've got a secret. There's no such thing as Alzheimer's disease anyway, Andy. All dementias are mixed. If you take a real brain out, there's a few Lewy bodies in it, and there's maybe vascular some minor disease, strokes and so forth. And so the issue is that there's the pure mostly Alzheimer's disease. Yeah, there's a mostly Alzheimer's dementia. And so, but a lot of things start going wrong with the aging brain. Right. And, there's this kind of various, I call it grunge. Grunge forms in old brains. Right. And it's probably, and the dementia causes the grunge, I think. I'm not sure the grunge causes the dementia. So preventing that stuff from forming may be a little bit like the famous analogy with tombstones. So if amyloid's a tombstone of dementia, and you remove the tombstones, what would that do? In other words, how much death could you prevent by taking the tombstones away? Right. I don't think any.
Not much.
So, the issue then is we need to move to the cause. We may not have knocked that out yet. Right. But I think that it's one of the great, necessary things. I think we'll probably figure it out in the next decade. Right.
Well, we did a series, Steve, you remember, on this for our psychopharmacology podcast series. We had a wonderful series of podcasts, I think it was 3 or 4, where we examined this, and we had some real great experts on this to help us. And I think you're right that we've wasted a lot of time and money barking up the amyloid tree. And there are some really exciting things going on. For instance, the GLP-1 agonists, the diabetes drugs, are highly neuroprotective, and actually one of them is being studied for Alzheimer's disease. People are going after tau now. They're looking at inflammation. So this is also an area of real active research, and I agree with you. I hope within our lifetimes we figure this out. But in the meantime, there's a lot of preventive things people can do. Simple things: managing your blood pressure, diet, exercise, quitting smoking, moderating alcohol, and so on, healthy diet, and so on. So
prevention of rather than trying to rescue is the issue. So, I think you're right that once you've got whatever this process is that's deeply embedded into your brain, the chances of even stopping it, let alone reversing it, are probably a lot less good than preventing it in the first place.
Yep, it's the old horse is out of the barn. All right, Steve, we have one last question, and this is fun. If dopamine and serotonin were rival gang leaders battling for control of the brain's neuroturf, which neighborhoods or brain regions would they claim as their territory, and what psychopharmacological weapons would they use to keep the peace or start a war?
Wow.
Yeah.
Well, I'll tell you, we know where the headquarters are for these gangs. It's in the brainstem.
Right.
So all the headquarters are in very small areas the size of a pea. And so we know where the headquarters are. So, and guess what? There's little spies that go from one headquarter to the other and back. And so there's some gang talk at the headquarters level. Yeah. But most of it is in the distribution of the trees of these fibers that go into the cortex. So the gangs are, in some ways, I suppose, fighting their turf in the projection areas of the brain. And although you choose in this particular question dopamine versus serotonin, there's a great deal of overlap between them. And so when you're out of balance, it probably is not a good thing. So hopefully what happens is that you find a truce and both gangs get their own turf and there's nobody in predominance. Because if dopamine's in predominance, maybe you're psychotic. If serotonin's in predominance, maybe you're depressed. And so being out of balance is not good. So in fact, that's part of the secret of a good brain. It's not whether you're too high or too low. Right. It's whether you're not out of balance. So keeping these gangs, kind of in balance is what we're trying to do.
As you've said, it's the circuits, nodes, and networks all have to be communicating properly. So I guess, and also we sometimes talk like dopamine and serotonin are in these tubes being carried through the brain, but if the brain's like a soup, these things are all floating around and there's lots of neurotransmitters and we're discovering new ones all the time we didn't even know existed, and they all have to be like the tar, the TARs, trace amines. Okay, well, Steve, can you believe the time has passed so quickly here? Not just this hour, but the past 20-something years that we've been working together. And, Jonathan Meyer and I are Grateful Dead fans, and there's a wonderful line, "What a long, strange trip it's been." So any closing thoughts, Steve?
No, but I'm just thankful to our audience for doing the great work that they do with patients.
Yes.
It's changing the world. The idea is that it can be frustrating at times, but just remember that you're making a difference. And my gratitude goes to the staff at NEI for all the things that they're doing to carry this forward, and also to the faculty such as yourself that are really taking it to the next level and keeping things going and keeping this whole legacy of what we've been talking about going and alive.
That was beautifully said, Steve. And for our audience, be sure to listen. This was the first in our series of NEI podcasts celebrating the 20th anniversary of NEI Congress. So please listen to the next NEI podcast episode in this series to hear more Q&A from some of our expert NEI Congress faculty. And of course, for more of our educational offerings, please go to our website, which is NEIglobal.com. Until next time, thank you.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.